Good afternoon and welcome to the Alabama Department of Public Health Training Network. Today we're having a very serious topic, and that is about supporting children in times of crisis. This program is brought to you by the South Central Center of Public Health Preparedness. You know, as we talk about the fact that in emergency preparedness, we're always, as a health department, we're always concerned about making sure that everything is okay, making sure that everyone is taken care of. We sometimes forget that the mental aspects of being taken care of are just as important as those physical aspects, and that's what today's program will be focusing on. As we're looking at the program, we want you to know that we are in partnership with state health departments in Alabama, Arkansas, Louisiana, and Mississippi, as well as the School of Public Health at UAB, UAMS, and Tulane University. And we do appreciate that funding from CDC to make this possible. Today, as we are talking about children in crisis, we do have certain objectives that we will be following. The objectives today, you will be able to outline practical advice, and let me put an emphasis on practical. Practical advice for parents on how to support their children in the times of crisis. You'll be able to list common symptoms of adjustment reactions of children in the setting of crisis and risk factors for adjustment problems. And lastly, you will be familiar with 4 basic principles related to preparedness planning to address the mental health needs of children in the setting of a terrorist event or a disaster. As I said, this is a very serious topic, and we have 2 special guests here today to discuss this with us. I'll be introducing to you Dr. Joshua Claypoe, and Dr. Claypoe is from UAB, and you are the investigator for the South Central Public Health Preparedness Association, so we're so glad that you're here today to join us with this.
Thank you very much. I look forward to the discussion.
And you're also an associate professor at UAB,
yes,
correct?
Yes, I am. That's correct.
And you've been at UAB for about 10 years, you said?
I've been there almost 10 years now, so quite a while.
You've seen a lot of things happen in those 10 years, I imagine.
Absolutely, and today's topic is very important, and I'm glad that we are discussing it today.
Well, as we're discussing it, I'll just turn it over to you and let you explain what we're doing.
Thank you. It's my pleasure. Good afternoon, everyone. It's my pleasure to introduce our speaker, Dr. David Schoenfeld. Dr. Schoenfeld is the Thelma and Jack Rubenstein Professor of Pediatrics. He's also the Director of the Division of Developmental Disabilities at Cincinnati Children's Hospital Medical Center. Dr. Schoenfeld is an expert in behavioral and developmental pediatrics, and I think more importantly, has extensive experience in areas of violence and crisis as they relate to children. His topic today is important because not only is mental health an important topic, but particularly when it comes to children, it's a topic that gets overlooked. And so I think that I know that I'm looking forward to both his research insights, but also his clinical insights, and I'm sure you all will enjoy it as well. And with that, I'd like to turn it over to Dr. Schoenfeld. Welcome.
Well, thank you, and
My
good
pleasure.
afternoon. Before I get started on talking about how to support children in times of crisis, I think it's important that we reflect first on the impact that crisis has on each of us. So if you look at this cartoon here, Calvin proclaims that "live for the moment" is my motto. He goes on to explain, you never know how long you've got. You could step into the road tomorrow and wham, you get hit by a cement truck. Then you'd be sorry you put off your pleasures. That's why I say live for the moment. He then asks Hobbes, what's your motto? And Hobbes replies quite simply, look down the road. I like this cartoon because it illustrates 2 of the very many legitimate but actually quite different perspectives that each of us have as we consider the impact of crisis events. And while all of us have very legitimate and very different perspectives, I'm going to ask for this next hour and a half that we join Hobbes and take his advice and look down the road so we can anticipate what the needs of children might be in crisis situations and better plan to prepare for them so that we can support children at those times. The issue comes up about why even consider mental health when doing crisis preparedness planning at a public health perspective. Well, as we've unfortunately seen, the psychological impact of crisis events, especially for terrorist events, but not only for terrorist events, is often far greater than the biomedical impact. For example, in response to the Scud missile attacks in Israel during the Gulf War in 1991, there were more fatalities and a great deal of morbidity from fear behaviors than from the missile impact itself. Anxiety resulted in fatal heart attacks, Individuals suffocated in gas masks that were used unnecessarily, and many were injured running to sealed rooms, and hundreds auto-injected atropine that was unnecessary. So we've learned that response plans need to be adequately informed by an understanding of the psychological and behavioral reactions of children and adults in crisis situations. Plans that don't take this into account may indeed be very effective in the very initial response phase, but only up until the point where people are actually involved as either victims or responders. Once you've reached that point, it's dangerous not to include considerations of the psychological and behavioral responses. You have to anticipate how people are going to react in crisis situations in order to create effective response plans. In addition, we need to accept the fact that emergencies create mental health needs, all emergencies, even if they don't result in mental illness per se. The psychological impact of a crisis, though, may result in psychological morbidity that affects a large number of people. It has the potential to be long-standing, and it may also be disabling. So communities, hospitals, and others involved in preparing for and responding to a crisis event need to be prepared to mitigate the psychological impact of these events on children and adults. Now, in the immediate aftermath of a major community crisis event, mental health approaches will fall into two broad categories that I'm going to be discussing today. Psychological first aid is provided broadly to those impacted by the event, and this involves offering psychoeducation and supportive services to foster effective and normative coping strategies and adjustment, and to accelerate the natural healing process. For some individuals, though, this will not be sufficient. The second complementary approach, therefore, involves timely and effective triage and referral in order to identify and deliver services to those children who would benefit from additional mental health care. I plan on beginning this presentation by offering you some very practical advice about how to support children and their families during and after a crisis. And when I talk about a crisis, I'm referring to either disaster or terrorism. And I will tell you that a lot of what I'm going to be discussing will be relevant even when working with children or families that are dealing with a personal event or personal crisis. I'm then going to outline some of the common symptoms of adjustment reactions and review risk factors that will help you identify which children are likely to benefit from additional mental health services beyond the psychological first aid. Lastly, I will briefly mention some of general considerations for hospital and community preparedness planning for terrorism and disasters as related to children's mental health. So let me begin with some recommendations we can offer to parents and other adults who care for children on how to support children after crisis events. Well, the first thing is that parents and other adults, such as teachers, need to inform children about a crisis event as soon as information becomes available. Even young children can sense when something bad has occurred and will become concerned even if they know little about what has happened and have been told little about what has occurred. Silence is rarely comforting in crisis situations, and furthermore, it implies that what has occurred is too horrible to talk about, and furthermore, that it's inappropriate to talk about such events and the feelings associated with it. So the silence at the time of a crisis will often lead to silence by children when we later wish to initiate conversations with them. Children, just as adults, are better able to deal with a situation if they feel that they understand it. Now, the amount of information to provide to children depends in part on their age, their personality, and their typical coping style. Older children and adolescents, in general, will require and benefit from more information than younger children. But no matter how old children are, it's best to state in simple, direct, and clear terms the basic facts. Then ask the children what questions they might have and what further information they would like. Quite frankly, if you can say something very clearly and directly and simply, there is no reason to elaborate it for any audience in your initial conversations. In the setting of a major crisis event, even adults are going to feel quite overwhelmed and will have difficulty processing information. So I usually recommend that people think about, when they're delivering difficult news, what explanation would likely be understood by a typical 5-year-old. And there's about a 50% chance that adults will understand that explanation. So I would start out in very simple and direct terms and then elaborate further based on the age and the developmental capacity and the coping style of the audience. Now, while it's important to inform children about what has occurred so they can feel they understand it, they don't need to have a lot of information necessarily. For example, I tell pediatricians when they're preparing children for surgery, say to have their appendix out, what you want to do is give them enough information so they feel comfortable with what's going to occur and understand it. They do not need enough information to fill in for the surgeon if the surgeon becomes unavailable. So a lot of the anatomical details and the very specific details are not helpful to them. They're going to want to know where the surgery will be done, what it's going to feel like when they wake up, where it will occur, where their parents are going to be, the relevant information that they need to be able to cope with the situation. And then if they wish further details, they should be given the opportunity to ask for them, and have them provided. In particular, you want to be sure to avoid sharing graphic details with children. Unfortunately, television and other media often provide this detailed and unnecessarily graphic information, which isn't helpful to children and quite honestly is not helpful to adults as well. So parents should limit the amount of television viewing of children around the time of a crisis, and if they are going to allow their children to watch television coverage of the event, they should consider watching along with them so they can explain what has occurred and what is occurring, and also help children process the feelings that are associated with what they are viewing. Another option is videotaping of media coverage that allows the parents to preview the material and then watch it at another later time in a more controlled setting where you can stop the tape periodically to discuss what you've seen. Schools in particular should establish a policy that explicitly discourages the use of live television in classrooms during the aftermath of a crisis. And I know on September 11th there were classrooms around the country where children were watching what was happening unfold on television with little support from teachers who were overwhelmed themselves as they watched the same information. Now, you should be prepared that children may not initially embrace the insights we share with them or offer to them regarding the negative effects of television viewing. In this cartoon, you see a mother is trying to explain that a new study says that TV desensitizes children by not showing the consequences of violence and suggests that they turn it off. Her son is saying back away slowly and does not really embrace the insight she's provided. Now, getting back to some of the questions that children will ask after an event. In the aftermath of a crisis event, children may inquire if another similar event could occur. And this question likely resonates strongly with parents who share the same concerns. But you have to realize that when children ask this question in the setting of a recent crisis event, they are likely not really asking whether or not it could occur. If they're able to form the question, they probably know the answer is yes. Often the underlying and the central question is not whether or not it could occur, but whether or not it is likely to occur, and more specifically, whether or not they should feel safe. Now, while crises serve as a harsh reminder that in fact we never are completely safe, after a crisis is the time to reassure children, to the extent that is honest and possible, that they are in fact safe and should feel safe in their school, in their home, and in their community. For example, in the state of Connecticut on September 11th, when the events unfolded in New York City, which is quite close to where we are located, there was a question raised about whether or not to cancel school and send children home. The decision was made quickly, though, that that would communicate the wrong message to children about their physical safety, and that in fact they were safest if they remained within their classrooms with the provision that parents would be allowed to pick up children if they so desired. So after a crisis event is an opportunity to reassure children of all the steps that the parents and other adults, including the government, are taking to keep them safe. But it's important to remember that children may have, in fact, very different fears and concerns than adults. So even if adults feel they have given all possible reassurances, it is still important to ask children explicitly what concerns they might still have. Now, this may uncover unwarranted concerns based on limited information or immature comprehension, and then we can explain why children do not need to have those fears. But it may also elicit very accurate and appropriate concerns, which can serve as a starting point for a dialogue, not for just false reassurance, but instead on how to cope with those troubling feelings. I'll give you an example from my younger daughter. She was approximately 9 or 10 on the events of September 11th, 2001. And after that, she asked about two different concerns that she had. One concern was that she heard a plane go overhead, and she asked some questions about the bombing in Afghanistan. She said that those are actually American planes that are dropping the bombs, aren't they? And I said, yes. She said, and they're using bombs from the United States. And I said, yes. And then I asked her, are you afraid that the plane that went overhead might actually be carrying a bomb and that it might fall on us? And she asked me to clarify why that isn't something she should be afraid of. So I was able to explain that the planes loaded the bombs closer to Afghanistan and that bombs flying over Connecticut were not an immediate concern. Later, a couple of weeks later, I came home and I found my family was finishing dinner and that my youngest daughter was not there. I asked my family where she was, and they said, well, she's in bed. She decided to go to sleep early and read. She said that the conversation had been bothering her, and that she actually preferred to read Harry Potter in bed because sometimes fantasy was actually better than reality. And I asked her what she was afraid of. She told me she had heard that North Korea was having nuclear capacity and that she was concerned that they might actually attack. And she was she was confused because she actually thought it was Afghanistan that had nuclear capacity and not North Korea. And so she was concerned that our attacking that country might actually lead to them dropping an atomic bomb on us. So that was something that I could help clarify, but it was also a concern that I never realized she had. No one had specifically sat down and talked with her about the nuclear capacity of other countries, but this is something she had obviously overheard on the radio or in other news media and had put that together. So I think what you want to do is explain why you children do not need to be afraid, but you also need to ask children why they might still be concerned, and not assume that just because they are quiet doesn't mean they're thinking about it and doesn't mean that they're not aware of what's happened. Let me go on to some other issues for how you talk with children. Now, just as adults, children may wonder what they could have done or what could have been done to prevent or at least to minimize a crisis that has occurred. There's actually an interesting special that was put out by HBO called Through a Children's Eyes, September 11th, 2001. And they interviewed young children around the country about their experiences around the events of September 11th. I think this was done within the year after the event. There was one child who appeared to be about 4 years of age who was somewhere from the middle of the country, not at all near the East Coast. And when asked what he thought about the events, he explained, "If I was at New York when the buildings crashed, I would just stop the bombs from going down. I would swing and catch it before it hit the buildings and then save the whole city's life." And then he paused, looked kind of sad and said, "But I wasn't there to help." Now, as you would ask, well, why would a child who's that far from the event have this fantasy that it was his responsibility to somehow stop the events of September 11th? Well, this is not uncommon with children, particularly young children. Especially if someone they know died or was seriously injured, they may feel guilty for some action or failure to act on their part, even if there's no logical reason to believe that they had any responsibility, and it's clear that there's nothing that they could have done to prevent or lessen the tragedy from the perspective of the adults around them. From a very early age, children are often encouraged to believe that their thoughts and their wishes can make things happen in the world, even things for which they, in fact, do not have any personal control. This form of magical thinking allows children to feel much more powerful than they actually are. But when something bad occurs, it also makes children feel much more responsible than they actually ought to be. Therefore, when talking with children, and even adults who carry some of the remnants of this magical thinking about a crisis, it's best to assume that there may be some underlying guilt, even if the child had no possible role to play in the events, and there's no reason logically to assume that they might feel guilty. Such guilt is associated with more severe and prolonged post-traumatic stress reactions. As you can imagine, children will obviously be reluctant to share such concerns with others, so adults should look carefully for signs of possible guilt and consider reassuring children of their complete lack of responsibility, even if there's no reason to suspect they're feeling guilty and they haven't voiced the question. Children may also wonder who else might be at fault and express anger at those that they perceive to be responsible for causing or failing to prevent the crisis, and that may include their parents and other adults who they count on a day-to-day basis to protect them and to make their world safe. This cartoon that's here with Calvin and Hobbes is, I think, a good explanation of why some of the guilt is there. Here Calvin loses Hobbes, and he runs in calling his mom and explains a big dog knocked me down and he stole Hobbes. Goes on, I tried to catch him, but I couldn't, and now I've lost my best friend. His mother then responds, well, Calvin, if you wouldn't drag that tiger everywhere, things like this wouldn't happen. Calvin's very perceptive when he notes, there's no problem so awful that you can't add some guilt to it and make it even worse. So when dealing with bad situations, I often tell people that it's understandable that they feel badly. And often when people feel badly, they believe they have done something bad. So I think it's important to anticipate the guilt reactions and to try and reassure children and adolescents, and to some extent adults, of their lack of responsibility. In terms of other reactions, adults should anticipate that children and adolescents may not initially respond to our efforts to engage them in discussions about the event or their feelings. This is especially true for older children and adolescents, who in general are used to turning to their peers to discuss issues of importance to them. It's generally not appropriate to try and force such conversations. Instead, adults should extend the invitation to talk on multiple occasions, remain physically nearby or present, but wait for the invitation to be accepted. You might also try by asking how other kids their age or in their class or their friends are doing, and this may in fact be less threatening to the individual child than direct questions about their own feelings and reactions. Now, while some children will appear to be highly impacted by a crisis in their community or elsewhere in the country, other children may appear to be disinterested and even irritated by discussion about or attention to the event. Children are generally concerned most about what impacts them directly. So if they are not immediately affected by events in the world, they may not perceive them as directly relevant to their lives. We should warn parents that children and adolescents tend to think mainly of themselves at times of crisis, at least at first. Once children feel they've had their own personal needs met, then they will be more capable of thinking about and addressing the needs of others around them. Adults, though, who don't understand this may interpret children's initial self-centeredness or disinterest as a sign of being selfish or uncaring. Instead, this may actually represent a sign that children are having difficulties dealing with the event, and paradoxically, that they require more of our caring and attention. And I know when I spoke to my younger daughter's elementary school on the morning of September 12th, right before school started, I warned teachers about this. And when I went to pick up my daughter after class, several of the teachers commented that that was very helpful perspective to them, because they could understand why some of the children just did not seem impacted or seemed to be very self-centered in the impact, and to see that as a developmentally appropriate reaction, and then support children until they were ready to start thinking about the needs of others. But children may appear disinterested for many other reasons. It may be because they don't know or understand what has occurred, they don't appreciate the short-term or long-term implications of the event, or they don't feel comfortable expressing their feelings, or are just feeling so overwhelmed by their feelings that they're not ready to talk about them. They may also conclude that in fact there's little to gain by discussing the event or their reactions, because it will change little of what has happened. So rather than focus on what could have been done to prevent a crisis, adults can help children figure out what they can do to assist others. And they may wish to spend a good amount of time asking children to reflect on how they think they can be helpful, instead of directly telling children what they ought to do to be supportive. Now, the preceding advice that I've given so far related to suggestions on how to promote normative coping for the general population of children after a crisis event. And I'm going to refer you to a couple websites for further information and resources on this, which you'll see on this slide. The American Academy of Pediatrics held a task force on terrorism. I was part of that task force for several years. And they have a website that has a lot of useful information, which you'll see the web address on the slide. And I encourage you to go there. It will have background information, have relevant articles. They have a section on mental health, and they also have links to a lot of other useful sites. In addition, the National Center for Children Exposed to Violence at the Yale Child Studies Center has a range of parent guidance documents and also information about the School Crisis Response Initiative that I coordinated when I was over at Yale at the Child Studies Center and Department of Pediatrics. There you will find guidance documents on how to talk to children about not only the events of September 11th, which can be modeled for other crisis events that may occur, but also on how to talk to children about death, how to talk to children about war, how to deal with these issues in classroom settings, how parents can provide some of this information, and a few of the documents have already been translated into Spanish as well. What I would like to do now is to turn to a discussion of some of the symptoms of adjustment problems that children may develop in the aftermath of a crisis, and outline the risk factors that will help us identify which children are most likely to benefit from some additional mental health support and services beyond the psychoeducational support. Now, how children and adolescents perceive and then respond to a crisis depends in large part on their cognitive, social, and their emotional developmental levels. This slide lists some of the potential symptoms of adjustment reactions, and many of these will be well known to anyone who's spent time with children in stressful situations. One of the symptoms is sleep problems, and that may be related to difficulty with nightmares, or maybe difficulty falling asleep, staying asleep, or frequent waking. You can have separation anxiety, which may also manifest as school avoidance, where children are afraid to leave their family and those that they care about in order to attend school for fear that something will occur while they are separated, and that may lead to them avoiding going to school. Children may manifest general anxiety as well as trauma-related fears. Now, the fears may be related to a repetition of some specific aspect related to the traumatic experience. For example, after a plane crash, there may be a fear of flying. Or they may instead have a more typical generic fears that you would see in children of that age group, such as an increase in fear of being alone or fear of the darkness. One of the challenges is that fears may actually occur after a trauma event that are not specific to that trauma. And I know this becomes an issue from a public health perspective when looking at emergency funding to support mental health services after a crisis. So if you have a child who's now more afraid of the dark, but it's actually after a plane crash occurred, it's sometimes difficult to sort out, is that an increase in fears that are developmentally appropriate and more general that's a result of the exposure to the trauma, or is it just a fear that the child would have had otherwise? In addition to fears, you may get generalized irritability, which leads to difficulties with concentration, and often this will be manifested as deterioration in school and academic performance. Now, I find a lot of times teachers and other school personnel and parents anticipate that there will be some academic difficulties after the child has been exposed to a difficult or traumatic experience. The problem is that they often then feel that if it's expected, that they should not do very much about it. So as a result, you may have a death in the family or another crisis occurs, and the child's grades start to deteriorate. And individuals allow this to continue, sometimes to see if they're going to actually pass the school year. Well, let me give you kind of a parallel example. If you had a surgeon who was going through a stressful experience, and it started to impact on their surgical technique, and the individual was making errors in surgery or not paying attention well, no one would wait to see how many different operative problems they were and whether or not his or her health insurance premiums went up after a year. They would intervene immediately. If you had a bus driver who was distracted and having difficulty paying attention to traffic, you wouldn't wait to see how many accidents they had accumulate over the year. You would intervene as quickly as possible. I would suggest that we need to anticipate that children will have academic difficulties after traumatic events and provide supports as quickly as possible so that children don't have to suffer with the additional stressor of academic failure on top of all of the other stress that they're dealing with. Another common reaction is developmental regression. And the regression that you may see, a lot of the developmental regression people are used to and anticipate. So if you're in a kindergarten class and you have children that had mastered toileting and you see that they start to have some toileting accidents, most people will attribute that to the trauma or the traumatic event that's occurred. But what also occurs is more social regression. so that you may see that children will become more demanding or more selfish, or may have more difficulty getting along with peers or family members. And this may be another form of regression that's trauma-related. We have to really warn parents that this is a sign that children are under stress and having difficulty coping, so they don't react back to them by placing more limits on them or calling them selfish or inconsiderate. Obviously, another reaction could be depression, or a sense of foreshortened future or pessimism regarding the future, where children will have difficulty projecting what they will be doing or would like to be doing sometime in the future, because they will have difficulty projecting themselves into the future. You may also see children have an avoidance of previously enjoyed activities. This can be particularly difficult sometimes to sort out how much of this is an adverse effect of the trauma and how much of it may actually be post-traumatic growth. So it's a typical example. You'll have a child who has a death in the family related to a traumatic experience. And after that point, they tend to stay home more. They're, say, a young teenager or they're in their mid-teens, and they say that they don't want to go to parties that their friends have. They don't want to hang out with the kids because they just talk about music and trivial things, but that they're more mature now and they can't relate to them as well. And so parents at a certain level who are also grieving and impacted by the same event often draw on this as a way of keeping their child with them to provide support to themselves. Now, the problem is that it may not be that the child has actually become more mature. It may actually be that they're using this as an excuse not to have to leave their family or to go out or to return to their prior social activities. If children, though, do not socialize with peers, then they have difficulty establishing peer relationships, and that has long-term implications for their ability to have adult interpersonal relationships. So if the child is saying, I no longer find what's interesting to my peers interesting to me, but they then go out and find a different peer group. They look into how they can pursue joining the Peace Corps. They meet with like-minded children to deal with other social and community needs, then that's fine. If instead it's being used as a way of insulating the child from social interactions, you may need to encourage the child to start to resume their functions. And I know in talking with people in New York City, such as guidance counselors for high school students who are graduating, they're having difficulty sorting out some of the altered career plans that some of these students are having and trying to figure out how much of it is because they now want to pursue a different career direction because of some post-traumatic growth, as opposed to a fear of entering into a prior career direction that may have required more travel for them or separation from family. So you may see some of these signs of depression and foreshortened future and change in activities. In addition, you can see an onset of or increase in previously noted substance abuse, and that has actually been seen at a national level after crisis events. Another common symptom of adjustment reactions that you'll see on this slide is somatization. Many of the children and families who would benefit from supportive services and or counseling after a major crisis event are not going to identify their difficulties as psychological or emotional in nature, but instead they may present with physical complaints. Pediatricians, school nurses, and other healthcare providers need to maintain a heightened awareness of trauma-related symptoms, such as somatization, and help these families understand so they can begin to address some of the underlying psychological issues. Children may also demonstrate symptoms consistent with the diagnosis of post-traumatic stress disorder, or PTSD. In this slide, it outlines some of the diagnostic criteria for PTSD, and these symptoms need to be present for at least 1 month for the diagnosis. The 3 areas involved are re-experiencing of the traumatic event, avoidance of stimuli associated with that event, and a state of increased arousal. Now, the re-experiencing of the traumatic event may be through such things as intrusive images or a sense that the event is somehow recurring, through traumatic dreams or just intense distress at physical or psychological reminders. As a result of this increased the recurrence of the re-experiencing of the traumatic event, you'll find that children will have an avoidance of stimuli, including even thoughts or feelings that are associated with the trauma, which can lead to psychological numbing and add to the foreshortened future. This avoidance, I want to emphasize, is a core feature of post-traumatic stress disorder and is one of the reasons why you really need to do active outreach in order to identify children and adolescents who are impacted by the event. Because individuals who have PTSD will avoid not only talking about it, but even thinking about it. So as a result, they rarely seek out help and support because that would mean that they would have to think about the events. There will also be a state of increased arousal, and that may be manifested in children as difficulty concentrating or sleeping, irritability or anger, or hypervigilance or an exaggerated startle. Now, I know I've just spent some time talking about post-traumatic stress disorder, but I want to emphasize that there actually are a far wider range of reactions and concerns that will occur after a major crisis event beyond just post-traumatic stress disorder or even post-traumatic symptoms. And in my opinion, there's been so much emphasis on the post-traumatic reactions and disorders in the lay literature and the professional literature that often we have failed to give adequate attention to the non-traumatic symptoms and problems that individuals may have. When a crisis results in deaths, the predominant adjustment problems for children who had a family member or friend who died in the event may actually be bereavement related and not trauma specific. For some children, a sense of sadness for the loss of others, increased concerns about safety of self and those that the children care about, or anxiety may in fact be the main reactions. Crisis events and other unexpected losses can also challenge our assumptive world. Now, most of the time we function under certain assumptions, and this is what allows us to go through our day without feeling overwhelmed about everything that could happen. We assume that when we get on a plane or a boat or a train that we will make it at our destination. We don't assume our luggage will be there. We don't assume that we will arrive on time. We don't assume that any food will be served anymore. But we do assume that we will get there safely and unharmed. When we send our children to school in the morning, whether it's that they're by foot, by car, or by bus, we don't assume they'll remember their books. We don't assume that they'll have their lunch with them. We don't even assume that they'll come back and tell us they've learned anything. But we assume that they will make it and return at the end of the day safe. When a crisis occurs, even if it doesn't impact us directly, it reminds us that we make a lot of assumptions every day. And as a result, it challenges and threatens our assumptive world. And this can leave us feeling very vulnerable, anxious, and unsettled. So this crisis can have this impact on us. So even though the vast majority of children will not demonstrate persistent post-traumatic stress disorder or even post-traumatic symptoms, they may not be able to articulate what is bothering them, just that they have some unsettling feeling. It doesn't mean that most children are not affected or impacted by the event. But parents and other adults who regularly support children, such as teachers, tend to underestimate the extent of children's reactions to a crisis situation, especially as related to internalizing symptoms. In other words, how they feel inside. This poster was actually one of the posters that was put up around New York City by Project Liberty some months after the events of September 11th. And it says here, if only the signs were this easy to read. Unfortunately, the signs are not that easy to read, and children don't put them on the back of their clothing and don't often tell us directly about how they're feeling. Well, why is that so? Well, children may attempt to withhold complaints of these symptoms because of concerns that they are abnormal or somehow inappropriate, or because they wish to protect their parents or other adults around them who they note are visibly upset. Parents may also be aware of the symptoms but fail to report them because they may not think the professional, such as their pediatrician, is interested in hearing about them, or just because they assume that they're normal reactions to an abnormal event, and therefore, why would you tell anyone about them? Let me give you an example of I was serving as a pediatric attending in a general pediatric clinic. One of the residents came out, and there was a 6 or 7-year-old girl who had been attacked by a pit bull the week before and had suffered lacerations on her legs. And it required a lot of suturing in the emergency room and was a rather deep wound. So the resident asked me to come and take a look to see how it was healing. Well, I asked, before I went into the room, I said, how is the girl doing emotionally after this attack? And he said, well, I spoke with her individually, and I spoke with the mother, and both of them said she was doing fine. I went into the room, the wound looked fine, and I asked the mother and the child, again, how is she doing? They both said she's doing well. So then before I left the room, I said to the mother, well, how is she doing in school? And the mother said, well, she hasn't returned to school yet. She's afraid to leave the house, that she might be attacked by dogs. I said, well, how is she sleeping at night? She said, well, she wakes up pretty much every night now screaming with nightmares about dogs attacking her. I said, does she startle easily if there are loud noises? And she says, yes, if anybody drops anything or the door closes, she jumps because she's afraid dogs are coming to attack her. So then I went over some of the things I've already gone over about how to support children, and I reassured her that we were available and interested in hearing about this. I scheduled a follow-up appointment for her to come and speak with us, not to look at the wound, but instead to talk about how she was doing emotionally. I gave her my business card, the resident gave his card, and we gave referral information if they wished to go to a mental health source in the intervening week. But before I left, I asked the mother, why was it that you told both doctors, that both myself and the resident physician, that everything was okay when in fact everything is not okay? And she looked at me and she said, if you got attacked by that pit bull, you would have exactly the same reaction. While I can agree with that, that doesn't mean that I wouldn't seek help. You don't see people saying that if you've been shot, that's a normal reaction to an abnormal event, and therefore you shouldn't seek medical care. I think we have to be cautious about some of the expressions that we use and the implications they have for requesting and accepting help. We have to remember that there is so much stigma related to mental illness as well as to mental health, that even in times of national crisis when all of us are impacted to some extent, the stigma remains as a significant barrier to help seeking. I also warn people that they should not say or ask whether children need counseling or support, but instead whether they might benefit from it. And if they might benefit from it, then it's our obligation to figure out how to make those services available and accessible to those who could benefit. Now, I'm going to turn to some of the risk factors that are going to help you identify which children are most likely to benefit from additional mental health services. And this slide lists some of those factors. Well, obviously, direct victimization of self or others close to the child, especially if injury or death is involved, or direct witnessing are major risk factors. In a survey involving over 8,000 students in grades 4 through 12 within New York City public schools, it was conducted 6 months after September 11, 2001. Half of the children who lost a parent or sibling had probable PTSD, as did 1 out of 4 children who had a parent or sibling who survived the attack and got out of the World Trade Center. You have to keep in mind that New York City Public Schools serves approximately 1.1 million students, and 11% of public school children had a family member or a close friend who was exposed to the attack. 1% actually had a family member killed in the attack. So if you look at the amount of psychological morbidity in terms of PTSD, just from that exposure alone, see that it's enormous for the city. Now, another risk factor is if children perceive, whether or not actually it's accurately, that their life was in jeopardy during the event, or if they had exposure to these horrific scenes, including indirectly through media, then they are at significant increased risk. The key point is that it's the perception of risk, not necessarily whether or not it's accurate. So if you were fleeing your school because your parent ran to your school and they lived somewhere in Alabama, and the parent came and said, the country's being attacked, we have to get out of here, and the child fled with their parent, that perception of their life being at jeopardy may lead them to have post-traumatic symptoms, even more so than a child who is in closer proximity to the Pentagon or the World Trade Center who wasn't as concerned or did not feel that their life was in jeopardy. So it's the perception of risk that often is most associated with post-traumatic symptoms. Children are at increased risk if the event results in separation from parents or other important caregivers, or if there's somehow a loss of property or belongings, or other disruption in their routine environment. Children who had prior psychopathology or prior traumatic experiences are also at increased risk of maladjustment. I often find that people will say, well, children who grow up in adverse situations somehow become used to all the deaths and losses and crisis. And that is not generally not the case. A crisis of any nature often awakens feelings related to a pre-existing or even past crisis that wasn't fully resolved that may actually assume a primary focus for the child or adult in the setting of a different crisis event. As an example, I was talking with teachers that were in New York City, and one of the teachers who had a kindergarten class explained that after a fire drill that was done 4 months after September 11th, she found some of her students in hallways and in closets hiding and crying because it reminded them of the events of September 11th. The events of a particular crisis will likely bring up memories and concerns about other crises, even if they're not logically associated with the current crisis. I went to go speak to one class. They were about second graders. One of the students had found a gun and had accidentally discharged the gun and shot and killed his cousin. And the cousin attended this class, and a week had passed, and the class had not yet talked about their feelings related to their classmate who died. His desk was still in the room, and they hadn't had any discussion. I went to go speak to the class, and as I was being introduced, 3 of the girls stood up in the back of the room, put their arms around each other, and started sobbing. I had only gotten to my name at that point, so I figured that was not the reaction that I would expect. I tried to continue with the conversation, but the kids kept wailing louder and drowning me out. So I took the 3 girls to another room, and I asked them what was their concern. 2 of the girls said, "Well, why don't you ask her first?" So I turned to this first girl, and I asked her what she was worried about. She told me that her mother was being beaten by her boyfriend, and that she was afraid that she was going to die, and would I please do something to help her. I spoke with the teacher and found out that the mother in fact had bruises on her face and had given a story that didn't make much sense, and we all agreed that it would be reported promptly and assistance would be provided, and I reassured the girl. This all took about 5 to 10 minutes. I then asked the other 2 girls what concerns they had, and they said nothing really. They were crying because their friend was crying, and they all said you can now go back and talk with the class. And that's what I did. The girls returned to the class, and I went in to talk about their classmate that died. The point I'm trying to make is when you go in to deal with one crisis, you will actually be dealing with all of the crises in the lives of everyone you speak to. And if you go in with limited resources or by yourself, you will quickly feel overwhelmed. So I do recommend that people anticipate this reaction as they start to plan their responses. What people fail to appreciate, though, is that children often experience traumatic events. In this same survey of over 8,000 students in grades 4 to 12 in New York City public schools that was conducted 6 months after September 11, 2001, nearly 2/3, or 64%, reported that they had been exposed to one or more traumatic experiences prior to September 11th. 39% had seen someone killed or seriously injured. 29% had experienced the violent or accidental death of a close friend, and 27% had experienced the violent or accidental death of a family member. Now, when this data came out, as I talked to other people around the country and outside of the country, I got the same reaction. Well, that's New York City these days. That's what you would expect. That doesn't happen in our community. So let me contrast that with some other data, the incidence of exposure to death in another city, in a survey conducted by Ewald and Perkins in 2 public high schools. They found pretty much the same results. 90% of these high school students reported having experienced the death of a grandparent, aunt, uncle, sibling, or someone else they cared about. 40% reported the death of a close friend their own age, and 20% had witnessed a death. These results are very comparable, except this study took place in 1978 in Kansas City, Kansas. The point is that no matter where you are in our country or outside of our country, loss and trauma is common experience for children, and they bring that to future traumatic events. So we need to make sure that we provide the support to help them deal with the other losses that they're still struggling to deal with. Returning back to risk factors, parental difficulty in coping is also known to be a risk factor for poor adjustment on the part of the child. We need to remind parents that they need to take care of themselves in order to be able to attend to the needs of their child. And finally, a lack of supportive family communication style or the lack of community resources and support place children at increased risk of poor adjustment. So we should be advocating for supports in community sites such as schools, and a lot of my work has actually been in the area of school crisis preparedness and response. Before I end the formal part of this presentation, I wanted to go over 4 basic principles related to preparedness planning to address the mental health needs of children in the setting of a terrorist or disaster event. And these are 4 very basic principles that I hope will guide your response. The first is simply basic needs are basic. I was working with the Yale New Haven Health System, and I was in a planning meeting. And they were asking questions about how to prepare for a potential situation of chemical terrorist event that would require decontamination of a large group of individuals. And I was being asked what their mental health needs would be. In particular, what counseling would we provide at that moment. So I pointed out that in that scenario, there would likely be large groups of people who were separated from their clothing, from their wallets, their cell phones, their car and their home keys, their cash, etc., rendering them naked, stranded, without means of communication, transportation, or the ability to purchase food or obtain shelter, and that I did not want to approach them and ask them what they would like to talk about. I kind of sense what they would want, and that's what I coined the term UWF, or underwear first. Also, for those in the mental health field, we can call it brief therapy. We need to deal with the basic needs of children and adults at a time of crisis before they're able to acknowledge and begin to address their emotional needs. And these basic needs include safety, security, food, shelter, and communication and reunification with family and other significant individuals. The same is true for adults, and it's true for adult professionals as well. Staff are going to have their own basic needs as well, and preparedness plans need to consider them as a priority. So such things as family disaster plans and notification systems for professional staff to contact family members as a crisis is unfolding become important to allow them to be able to attend to the needs of the patients and community members that they will be asked to serve. Now, this is not to say that basic needs come before mental health needs. In many ways, they come together. And many of the attempts to deliver basic needs are actually for emotional and supportive reasons. When I talked with the New York City public school system that provided the food services for rescue workers at Ground Zero, they explained to me that they had to adjust their menu from what they normally served to increase the amount of comfort foods that they provided to the workers. When you have a family that's dealing with a crisis situation and you offer them something to drink, it's not because they're really thirsty. It's in part because it's nurturing. When you provide them shelter, it's not because they would die of the elements if they waited outside for 6 hours, but it's because they'll feel more comfortable and supported if they're in a safe and comfortable environment. So as you attend to their basic needs, realize that you're providing also for their emotional needs and combine them. So the next major point I wanted to make is that mass casualty events generally involve masses. So we need to consider issues of crowd management and planning, and many plans do consider that as a safety issue, but it's not just a safety issue, it's also a mental health issue. Chaos is unsettling, and poor crowd management can escalate safety concerns. Individuals with adjustment problems related to the crisis are going to be least able to successfully negotiate a confusing or overwhelming response environment. I always say to people in the medical community, all you have to do is walk into a hospital or into a clinic building, and you can find people who have been given bad news. They're generally the ones who look lost. And it's difficult enough to make it through a hospital to find where you're supposed to go, but when you've just heard bad news, it's very difficult to find your way. Magnify that in a major crisis event, and you will have a lot of disoriented and confused people. So we need to think about how to manage the crowds and do it in such a way that we're also being supportive to them. The third point is that children generally are part of families. So as a result, hospitals and practices may need to care for families as intact units. Adult hospitals may therefore need to care for children in the setting of a major crisis event, and children's hospitals may need to treat adults who may often refuse to leave their children for decontamination or for treatment. We see this all the time in emergency rooms in children's hospitals, that parents who are also physically injured, if they do come to the hospital with them, will often wait to have their own needs attended to until they're sure their child is okay. So we need to plan that we're going to have to treat them often as intact units. The fourth general point is that communications during a crisis, about a crisis, should not be a cause of crisis in and of itself. There are two basic reasons for public communications in the setting of a crisis. One is to reassure, and the other is to provide information to direct people to take specific actions to decrease their risk of an adverse event or to decrease the impact of an event that has already occurred. So risk communications need to be informed by these mental health considerations. You want reassuring announcements to in fact be reassuring and not sensitizing. And if instead you're providing information as a call to action, you have to be sure that you're actually recommending something concrete they can do to decrease their risk. That will optimize the likelihood that people will understand the message and respond in the desired manner. Now, we would like to think that we could prevent crises in children's lives, and we should make every reasonable effort to do so. But unfortunately, it is unlikely that we can prevent all major crisis events from occurring. So what can we do? Well, there are a couple things we can. One is we can identify and address children's underlying vulnerabilities that place them at an increased risk of adjustment difficulties in response to a crisis. We can help them enhance coping skills so they can draw upon them in a crisis situation. Individuals who are faced with a crisis event and cope with it often come out of those events with additional skills and resiliency, and that's what we're referring to by post-traumatic growth. So we can help further that. We can also promote the creation of an infrastructure to optimally support children and their families in times of crisis. And when a crisis does occur, we can ensure the early identification, triage, and intervention for adjustment reactions at those times. So at this point, I'm going to stop and open it up to questions. So thank you.
At this time, if you have a question, we would encourage you to use our toll-free number, and that number will be appearing on the screen in just a moment. Please feel free to call your questions in. That's 1-800-946-6307. Or if you prefer to fax your question in, that will be fine too. As we were talking, as we were listening to the presentation, first of all, you think, when you first start, you were thinking, well, crisis, 9/11. But then as we're going through the presentation, it dawns on the listening audience that a crisis could be most anything that's not normal in a daily life. So I guess my question is, if I'm a nurse in a health department and I'm seeing a patient or I'm seeing a client and I'm wondering if something's going on that might have been stressful or a crisis in that life, how do I know how far to ask the probing questions?
Okay.
How do I know? They told you first, no, I'm fine. They told the other doctor, oh, she's fine. How do we know how far to go?
Okay. Well, first off, one of the points that you make is that crisis can occur on a daily basis to people, and unfortunately it does. So that a lot of the skills that I'm hoping healthcare providers and public health officials will develop are going to be relevant to day-to-day lives. Just the same way we don't want to only prepare for weapons of mass destruction. We want to set up a public health infrastructure that can help us deal with more common but significant public health needs. Same way we want to provide for mental health needs on a day-to-day basis. So, and the point that you're making also is that all staff that interact with families should be prepared to provide some psychoeducational and supportive services. So I know when we developed training material for the Yale New Haven Health System, we encouraged all staff to learn the basic skills because, quite honestly, they're the ones who are going to deliver it. Often it's people in the cafeteria that see the families who are upset and can provide some support. It's people who come and clean the hospital rooms, who often are the ones who can tell when somebody is really is upset and can also offer some support. You asked a question about how far do you go. Well, I think the issue is that you don't want to probe a great deal, particularly in a major crisis event, because you won't have the ability to attend to everything that you uncover. But more what I'm referring to is not so much probing, but anticipating and being supportive. So if I see someone in the hallway who looks lost, I don't start probing to ask them, did you just get bad news? Instead, I say, you know, hospitals can be pretty confusing and overwhelming places. Can I help you with something? Can I help you find it? Would you like me to actually walk you part of the way there? Now, normally you would just give directions and walk away, but I know that sometimes the individuals aren't ready. I'll give you an example. I was attending in a pediatric continuity clinic, and it was the week that new residents in training started. And one of the interns was kind of slow near the end of the day, and I looked at her and I said, were you on call last night? She said, yes. I said, did you get any sleep? And she said, no. And I looked at her and I said, are you okay? And she said, oh, I'm fine. And then I asked her, did you eat breakfast? And she said, no. I said, did you eat lunch? She said, no. I said, so you haven't eaten since about 6 o'clock you haven't eaten about 20 hours. She said, well, not really. I said, then you need to eat. She said, well, I can't. I have patients waiting. I said, then I am getting you food, and you will eat it because you need to. So then she started to eat. She said, I feel a little bit better. And I said, in the future, you must make sure you have meals. Then I looked at her at the end of the day, and I said, you really should leave now. Any notes you're writing probably don't make sense anyway. It's been a long day. We no longer actually allow residents to work long hours, and that's good. And then I said to her, you really should go home. And she said, fine. And then I looked at her and I said, do you know where you parked? And she said, I don't remember where the garage is. And I said, let me walk you there. And then I brought her to the garage. I said, do you remember where you parked in the garage? She said, yes, I'm okay now. I said, can you drive home safely? Would you like me to drive you home or arrange for other transportation? She said, no, I feel much better now. I've eaten. I'm okay. I can make it home. The point was not so much, I didn't probe, but I just anticipated. And I asked questions, and I provided what I thought might be helpful, or at least offered it. And I think that's what you want to do with families.
Josh, sometimes I think that same, I guess, taking that extra step maybe is what we're talking about. What about families that were raised, we don't share our family business?
Well, yeah, I mean, one of the things that I was struck with in listening to the presentation that I hear frequently, this is just common sense, and yet, if it's common sense, then we'd all be doing it, and yet we don't do it. How do we remind ourselves as public health professionals that this is, whether or not it's common sense, it needs to be done, because the very scenarios that you described in the question are the very things that get overlooked. Mm-hmm. We typically don't think of it as a mental health problem. It's somewhere between being nice and customer service. But how do we remember to do these sorts of things in with families, who are not necessarily going to share their laundry with you?
Well, quite honestly, most of what we do, whether it's in medicine or in public health, is based on common sense. The difference is we value it and we train it if we think it's unique to our discipline or is what's expected of us in our job. So the first thing is to value it, to realize that it is important to the clients that you serve. It's important to the people who work with you. It's important to yourself. I think once you accept that, then you start to see that that is really helpful. And quite frankly, it's something concrete you can do. I remember the first time I had to speak to a family about their child who was dying, and there wasn't anything further that we could do. And I made the conscious decision, I can get them some orange juice. That's something I can do. I can be with them. I can talk with them. I can be supportive of them. And that was very helpful. And as it turned out, their child got better and recovered fully. But the issue is you need to realize and you need to value that these are important things to do. Mm-hmm. And then you can feel empowered by what you're doing is not taking you away from your job. It is part of your job. Mm-hmm. And in a major crisis event for public health officials, it will probably be the best thing that they can do for most people. Obviously, there may be situations where they can actually change the event as it unfolds and decrease the morbidity and the mortality, and obviously they need to do that. But your average person, the vast majority of the people, are going to have their greatest impact on attending to the mental health needs of the population.
Another question, and I was struck when listening to the presentation. I know we're focusing on children, but I found myself every time you would give examples, et cetera, and I know you said this applies to adults, or could be to adults as well, but again, how do we as public health professionals who are adults be aware or take note of what may be going on for us, not just in terms of sleep and food, but the psychological reactions to an event that may affect our ability to provide services But how do we do that early on so that we're not dealing with it when we can't function like the resident that you described?
Right. Well, I think from a pragmatic level, you need to identify what your needs are and then make sure that you attend to it. I remember going to a meeting on September 12th talking about how to respond to the mental health needs of children in the state of Connecticut. And right before I went, I stopped off at the cafeteria and I picked up a sandwich and I picked up another sandwich for someone I worked with and brought it to the meeting, and I anticipated he wouldn't have picked up food. And I said, you've got to eat. This is not going to be over in a day. We're going to have a lot to do, and you need to space yourself. You need to attend to those needs. And he said, thank you. Otherwise, I really haven't eaten much. I said, I know. But if you're hungry, you're not going to be helpful. So some of it is just anticipating what your needs are and realizing that it's acceptable to meet some of those needs as you can. Now, I wouldn't stop and get a sandwich in the middle of trying to resuscitate a child who was dying, right. But I would try and get something to eat if a day had gone by, and I knew that I was going to continue to need to work. So some of it's just accepting the fact that it's okay to have human needs, even when you're a professional, and that you need to attend to them as best you can. You should also anticipate what those are. And try and put plans in place so that you're not worried as much about your children and your family. You have a disaster plan in place. You know who else will take care of them. You're able to just check in, and you have a system for checking in already planned so that you can attend to those needs. I actually gave a presentation to the National League of Cities just at about the time we were starting to attack in the Middle East. And it was right before we attacked in Iraq. And there was some discussion about, they wanted me to talk with them about how do you help prepare for war. It hadn't been announced yet, but it was anticipated it would. And so the individuals at this meeting were legislators from different cities, people who have leadership positions. And one of the other people on the panel had actually been the head administrator in a major city on September 11th. And he said to the group, I remember the first issue that came to mind of what I needed to address when I found out that this might be impacting my city. And that was, is my family okay? Now, few people will say that, but that was the issue. He said, once I knew that was okay, then I could deal with the millions in the city I was responsible for. So I think we need to think about what are our needs and make sure that we have plans to address them. The other issue is we need to have some appreciation of how the situation is impacting us personally so that we aren't just reacting, we're also understanding our reactions. And I find that I do a lot of work in crisis and bereavement, and I know it has an impact on how I approach certain things in my day-to-day life, but I try and be conscious of them, reflective on them, so that I make reasonable decisions that are not just reactions to the way I'm feeling.
It's important that we realize that we are people at the same time and that we're going through the same crisis. I would encourage you, if you have a question or a comment, please call. And at this time, I think we have a call from Missouri. Missouri, if you'll go ahead with your call, please.
Yes, I was wondering, in helping hospitals plan, what are some of the suggestions that you would make to children's hospitals to be able to prepare for adult patients coming in and vice versa to hospitals that normally care for adult patients when they may be seeing children? And what kinds of planning are you seeing going on within hospitals to take care of those issues?
Okay. Well, let me start with children's hospitals.
Thank you.
Most children's hospitals already face this on a day-to-day basis to some extent. One of the employees might have a heart attack in the middle of the hospital. A child's parent who's visiting might also faint or have a seizure in the hospital. So there needs to be somebody in the hospital that can attend to the medical needs. I think there's an expectation that there will be medical needs of adults. But often that's just to stabilize and then transport, particularly for children's hospitals which are physically adjoining children's hospitals. Children's hospitals that are more physically separate from the adult hospital will often already have in place in their emergency department some supplies and have some professionals who also feel comfortable dealing with adult medical conditions. Plus, as children with developmental problems and congenital problems live to adulthood much more frequently, we're finding, in fact, a lot of adults are actually admitted to children's hospitals. But what you're going to need to do for the planning is to consciously think about the fact that you may have a larger number of adults who will not only need their kind of emergency care, but may actually need longer-term care, and if you're quarantined, it may be for quite some time. So that you need to look at the supplies that you would need to make sure that you have, IV tubing, equipment to intubate adults, ventilators that can be used with adults. So you need to think about actually the types of problems that adults will be having and make sure that you have the necessary equipment and pharmaceuticals, and that your staff is developing some of the expertise to be able to deal with some of the most immediate medical problems of adults. Similarly, adult hospitals may be used to transporting their children that present, but again, they may have children visitors, they may have children who are family members of adult staff, so they should have some expertise already in dealing with the most emergent needs. And particularly for adult hospitals that are not physically close to a children's or dedicated children's hospital, they will already be facing that on a daily basis. So again, it's just to look at the equipment, the pharmaceuticals, professional development, and make sure that you're ready to deal with the needs of the different population for at least some period of time after a major event.
Does that answer your question, Missouri? Well, I guess by that response, that means that you answered the question.
And one practical advice would be, if you're in an adult hospital, involve a pediatrician in your disaster and crisis preparedness. And if you're a children's hospital, make sure that you have someone who also treats adults. Particularly in the emergency department, there will be people who also have adult training, and ask them to sit in and talk about, well, what about the adult needs? What about the needs of all of our staff? If all of our staff need medication because they may have been exposed to a particular event, how do we meet all of their needs as well?
Good questions.
I was thinking, could you maybe comment on sort of some general percentages or numbers of people who are going to be impacted by a crisis, or everyone's going to be impacted to some degree? What are we to anticipate in sort of the number of people who, if not cared for or provided psychological first aid, are going to go on to develop more serious problems? I mean, are there some general numbers that we can just sort of keep in the back of our head?
Okay, I think it's hard to give exact numbers because it is so dependent on the particular event that occurs and the extent of disruption and loss associated with it. After a major event in our community or in our country or in the world, we are all impacted to some extent. People always say we can't go back to the way we were. You never go back to the way you were. When anything positive or negative happens, if it's significant, that's what makes them significant events. So I think people are impacted, and they will often carry parts of that with them forward. If you look at people who were alive during the Depression, they still treat money differently. And that has implications for their savings, it has implications for their investments, it has implications. And people see that and they say, oh, well, they grew up in the Depression, that's why they're this way. So there is an impact that it has that can be quite long-term. That doesn't mean that they become mentally ill. So usually when we've been looking at the mental health needs in the hospital preparedness planning, we talked about kind of 3 different levels. The first would be kind of the psychiatric emergency. Those would be individuals who are very disorganized, highly disruptive, maybe psychotic, maybe suicidal, unable to really manage or contain themselves. That will actually be a very small number. Handfuls is what you might expect in a major event. Those individuals need to be anticipated. You need to have some secure area where you can provide the mental health services to them that's supervised, because you don't want to send them all to the cafeteria if you have someone who really is that disorganized or disrupted. Those will be the individuals who may benefit. Some of them may benefit from medication. But that is actually going to be a handful. Then you're going to have a group that's impacted. Either they have major risk factors based on their exposure, or they're already showing some distress, concern. Those individuals don't need a secure area. And whether that's going to be 5% of the people that come there, or 20% or 60%, again depends on the size of the event and the scope. Those individuals will probably get brief interventions, maybe in groups depending on the size of the scope of the event, or they may be provided some individual services, and they'll be provided referral recommendations. Then there'll be a larger group that may just be impacted but not showing any symptoms, not having major risk factors, that you may want to give supportive services and psychoeducational services, more routine and more in groups. So how much the second and third groups are going to be is going to depend on the actual event. The other thing is, I've often seen hospitals refer to in their planning the worried well.
Right.
That's a term that I don't like, because it suggests that if you have mental health problems, you're well, and you're just wasting resources for those who are really sick. So I call them more kind of concerned individuals who are worried about exposure, or individuals who are physically healthy but concerned. And how many of those you're going to have will depend in large part as to whether we provide for their services elsewhere and have another option of where they can go. Because if we don't provide mental health services in the community, they'll probably come to the hospital in much larger numbers. So in an individual event, it's hard to tell the percents, but I would say probably a very small percent will actually be psychiatric emergencies or mental health emergencies. Probably a modest amount are going to be impacted significantly, and the vast majority will just be impacted in a lesser but perhaps significant degree. But it helps you at least in terms of prioritizing the services you provide immediately.
Did you have a question?
It was on a different area, though. What I was wondering is that picture that you showed of the cartoon, and the mother was turning off the television because of the numbing effect. She was afraid that her child would be so numb. Are you seeing that as far as our youth playing all the video games, and then when a trauma does happen, they're not as concerned as they should be?
Well, some of it is it may have a numbing effect. It may also have a sensitizing effect. I think we assume that if children are exposed to something frequently, they get used to it. But they may actually become sensitized to it. So it's hard to tell for the individual child. And you'll see such a range of reactions. On the morning of September 12th, I was talking with teachers in my daughter's elementary school, and the school day was just starting, so they were just greeting some kids. Some kids weren't even talking about it and seemed unaffected. And another teacher said the child was throwing up in the car all the way to school because he was so anxious. So some kids will see the same thing and be highly sensitized or upset about it. Other children will seem to take it more in stride and become more used to it. There is concern about in violent videos, particularly where the individual has to become a shooter in it, that does desensitize them somewhat to understanding or appreciating the implications of pulling a trigger. And that's some of the concerns that I think you hear in the literature and see. But I think there's sometimes children just become highly sensitized. I remember one parent of a second grader that came to see me because her child was watching Freddy Krueger films, and as a result, he was too afraid to be separated or alone. So the mother could not even go to the bathroom without him in the room because he was afraid that Freddy Krueger would attack him whenever he was left alone, because that's the theme in the movie. At the same time, he felt like he had to keep watching them. So somehow he could develop some mastery over it, but he was just becoming more and more sensitized to it. So children may repetitively see things and become desensitized. Sometimes they become sensitized. Either situation is not good. I mean, we want individuals to have reasonable reactions to things that occur, not to be desensitized to horrible events so that they're meaningless to them, and not to be so sensitized that they're concerned or agitated and worried about it happening. So repetitive viewing of traumatic events is not helpful to the general population in either case, but you can see both reactions.
Interesting.
What role, a lot of, we talked about a little bit earlier, that's a lot of this is, it is common sense, it is paying attention to basic needs. It doesn't require that you physically do anything. This is not surgery. It doesn't require any tools. And so a lot of it is in the communication. And I just kept thinking, what role do you think the media, or so the mass media, can play, given that in a crisis, in a hospital, we're not going to be able to provide, even if it's brief, individual interventions for a lot of people, and yet some of the messages and the advice that you're putting out here seem to be reasonable to communicate in other ways. And what role does the media, or can the media play to help us address these problems in large numbers?
Okay. Well, the media does and can play a very important role in crisis situations. And so I think it's important to work with the media to start planning for what they would and could do in a crisis situation. There is no better way, really, to get a message out about what you can do in a crisis situation than to use some of the public media. The issue is that media are not in place, and their driving force is not public good. They are not a public service. Predominantly, it's often decisions are sometimes made on financial decisions, and so as a result they may appreciate what I'm saying, but that may not drive some of the decisions about what they do. So I think it becomes very important to meet with media before the next crisis event to talk about how they could best handle it. And I think if they understand the potential negative implications of what they do, and they think of ways of trying to minimize those negative effects and build on their potential positive impact, I think then you can see that often you will be able to work on compromises. I was in a kind of unusual situation where I was at a press conference, and probably about a month after September 11th, and we were talking some about the media's effect. And one of the reporters asked me, well, why is it that the media keeps showing these things if they're harmful? And I just kind of paused and said, well, that's really a question I should be asking you. I mean, just because we know something is potentially harmful doesn't mean we don't do it. That is true for individual behavior, and it's true for group behavior, and frankly, it's true even for professional behavior. Mm-hmm. So I think we need to enter into conversations with media now, practice that in terms of when there's a lesser event that still impacts people, use the same better communication between public health and media, and figure out how media can be part of the solution. And as they become more and more part of the solution, I think it will drive the practice, because it will drive the expectation of what the media ought to do. And quite frankly, most people in media want to do the right thing and want to be helpful on a day-to-day basis as well as in a major crisis.
We want to thank you for joining us today. This has been a wonderful program, learning how to help children in crisis situations, as well as thinking about adults and how we're working with ourselves. I think one of the key messages is planning. Planning always will help prevent a crisis from being as much of a crisis as it is. And everything that has been said today leads back to that. We'll just think about it, plan it, follow through, and be prepared. And we certainly appreciate this wonderful information. I know if you have been able to view this program, you will want to have other staff who maybe were not able to view the program today. We do have this up on webcast. It will be there by tomorrow. So if you would like for your other staff, or if you would like to sit and review this information again, please just join us at our ADPH website, and you'll be able to see the program. We have an evaluation form that you would have received, and we do want your evaluations and your comments so that our programs will be more helpful to you. So again, if you'll just check that website, you'll be able to fill out that evaluation form. Our future programs we'd like to keep you up to date about. On August the 11th, the future program is Supersizing of America, the new challenge of obesity. And as we know, obesity is the #1 epidemic in the States right now, so please join us on August the 11th from 1 o'clock to 2:30, and that is Central Time. On August the 17th, we'll pick back up with this train of thought and look at emergencies and stress management and care for those first responders. Again, we'll be talking about taking this message a step further and thinking about those first responders and how to take care of them. That's August the 17th, which is on a Wednesday, from 2 to 4, and that again is Central Time. On August the 23rd, we have temporary food events, environmental issues concerning permits and inspections. That's always interesting if you eat in a restaurant, as we all do. So again, August the 23rd, that's a Tuesday, from 2 o'clock until 4 o'clock. And then on August the 24th, agriculture security, looking at factors and implications of this security. That's August the 24th, a Wednesday, from noon until 1:30. Again, we want to thank you for joining us today, and we trust that this has been a very beneficial program.